All right, I'd like to introduce our two speakers for this session. I'll introduce both of our speakers now, and I'm starting off with Dr. Angelina Marinkovic, who is a hematologist with a focus on sickle cell disease and inherited red blood disorders. She's a member of the Provincial Adult Red Cell Disorders Program at St. Paul's Hospital in BC. Her clinical interests include improving access to comprehensive sickle cell care, advancing disease-modifying therapies, and supporting the integration of emerging treatments into practice. Please join me in welcoming Dr. Marinkovic. Dr. Auro Viswabandya is an associate professor in the Department of Medicine at the University of Toronto and a staff physician in the Hans Mesner Allogenic Stem Cell Transplantation Program at Princess Margaret Cancer Centre. He has helped develop one of Canada's adult sickle cell transplant programs. His clinical and academic interests include allogenic stem cell transplantation and equitable access to curative therapies. Let's welcome Dr. Viswabandya.
Challenges here.
There you go.
I think that this works.
And a reminder that we're going to have a Q&A session at the end of both talks. So please hold your questions till the end, but there will be lots of opportunity to ask those questions.
Great. Thank you. Can you all, okay, you can all hear me, right? Okay, perfect. Thank you so much for the introduction. Thanks all for having me. It's been such a great experience. It's my first time at SCAGO, so thanks for having me from the West Coast. Today I'll be talking a bit about kind of the journey a patient might take when considering gene therapy and what we should be thinking about to make that journey safe and successful here in Canada. These are my disclosures, none of which will influence what I talk about today, but one of my disclosures is that I am not a transplant expert, I'm not a cellular therapy expert, I'm an adult hematologist that works with adults with sickle cell disease. And so that's kind of the lens I'll be talking through my presentation today. So what I want to talk about a bit, that has already been covered was gene therapy and kind of the landscape of gene therapy within the Canadian context, and then I'll go through the meat of it, right? The journey that a patient might take and highlighting the things that need to be done or that should ideally be in place to make this successful. And it really aims to kind of answer that question that our patients might have in that, okay, if I'm considering gene therapy, what does that mean for me? You've already heard about this, but there are standard of care, right? Disease-modifying therapy, hydroxyurea, replacement therapy, and other investigational therapies. These don't cure the disease. On the other side, there's transplant or allogeneic stem cell transplant and gene therapy, which aim to cure the disease. Something that I do stress for the curative therapies is that they don't change the way sickle cell is passed down, right? So sickle cell is passed down the same way with or without these curative therapies. And so that's something to mention to our patients when discussing these therapies. What is gene therapy for those of you who might not know? Dr. Klassen had talked a little bit about this, but it's modification of a patient's genetic material to treat a disease. And in sickle cell disease, there are two sort of main kind of aspects. They're gene addition, where you're introducing a functional beta globin gene, and that's kind of lovo-cell, but that's not unfortunately available here in Canada. And on the other hand, there's gene editing, where you're making precise changes to the DNA. For exa-cel, for example, which is the approved gene therapy product in Canada, it in a way, makes those changes to increase your fetal hemoglobin. And then there are other sort of modifications that we can do as well. Now, this was already mentioned, right? Exa-cel is the only approved gene therapy product in Canada, but just because it's approved doesn't mean it's funded, doesn't mean it's delivered, right? So nobody outside of a clinical trial, as Dr. Klassen had mentioned earlier, has received gene therapy in Canada. On the other hand, for transplant, or for adults undergoing allogeneic stem cell transplant, there are only really 3 centers in Canada that provide this to our adult patients, and that's here in Toronto, in Ottawa, and in Calgary. This was already, and I'll go quickly through this, but for Exa-cel, the approved gene therapy product, what do we know about it? So this is from the 2024 CLIMB SCD trial, where 44 patients received Exa-cel, and at that time, the median or the follow-up period was up to 4 years, sort of anywhere between less than a year to up to 4 years. And for those patients, 44 out of the 44 patients engrafted and didn't have sort of any graft failure. And then over 95% of these patients were free from a severe vaso-occlusive crisis. You saw that pictorially, right, earlier. With these patients, there weren't any evidence of kind of failure of this graft, of this sort of gene therapy product. No secondary cancers, no problems with the bone marrow. But the honest caveat is that we don't have enough data yet, right? This is only at most 4 years for this particular product. So we need more time to know the true incidence of durability, secondary cancers, and et cetera. Okay, so this is the meat of it, right? So this is a schematic of what I might imagine a patient might take as a journey when considering gene therapy. And so you can see here, it's kind of broken down. This clicker doesn't really work, but it's broken down into different phases and different steps that I like to think about, right? And so this is something that I imagine when I'm talking, or when I'm going to be talking about patients, or with patients that are considering gene therapy. As you can see here, the process can take more than 6 months, more than a year from that initial discussion to the infusion of the cells and to long-term follow-up. So it's a long journey, right? And it might look a little bit different for every patient, and different centers might structure these phases a little bit differently, but it's a similar overall framework. And as of yet, so only recently have there been publications for recommendations on how to deliver gene therapy outside of sort of clinical trial protocols. And we haven't yet done it in Canada, outside of clinical protocols. Okay, so let's go through the details of it. So the first sort of phases include that initial discussion with our patients about, what gene therapy is and what this journey looks like. But I actually think that this is one of the most important kind of visits. When people come into my clinic wanting to talk about gene therapy, we actually start talking about their sickle cell disease. And we try to make sure that we're meeting the bare minimum first, the standard of care first, right? And a lot of the times I'm re-engaging someone with the clinic that might not have been engaged for a long period of time. And so this is that really important step. So exploring their sickle cell disease, their options. Now, once we've done that, and talking about that initial discussion can happen over multiple visits, right? But let's say our patient decides, okay, I want to embark on this journey. Then they might go through sort of that comprehensive evaluation where they meet with the cellular therapy or gene therapy team, undergo organ and infection disease screens, talk about fertility, all of these things working together to make that shared decision amongst a multidisciplinary team on whether it's appropriate to move forward. And these are some questions that I would sort of encourage patients to ask when thinking about these phases, sort of, okay, what tests do I need? How long will this whole workup take? What other options are there? And what if something's abnormal? Okay, so what is now needed to make this smooth and successful? These are some things on the system side that I kind of think about. And I think one of the central roles here, or relationships, is a relationship with our cellular therapy or transplant or gene therapy experts, right? Someone that understands sickle cell disease, understands disease-modifying therapy, understands transplant, understands gene therapy, and can counsel our patients, but not only that, make sure or and ensure that sickle cell disease has a place within that cellular therapy program. Apart from that, decision aids with honest framing tools around the unknowns, the duration, the risks are really important for our patients to have. Evaluation checklists on what's required, right, so that we're not, and that are standardized so that we're not repeating something or missing something. Testing like available HLA typing that's readily available for our patients, and transfusion medicine that can help guide those early discussions need to be in place. As you can see, there's a lot of moving parts, right? And so navigation coordinators for all of these moving parts are important. Now, I've also noted here demonstrated adherence. So, what I would say is really important that our patients, there is some sort of demonstration that they can follow up with our program, right, and test, because this is quite a large journey and a long journey that requires commitment. But from our side, we need to make sure that we're providing our patients with enough support from that side. There's people that have variable health literacy coming from a variety of places, a lot of different countries, right? There are people that might have faced neurocognitive challenges because of their sickle cell disease as well, right? And so having psychosocial nursing roles, mental health roles that are established within the care team is essential to make that happen. And amongst all of this, kind of an informed consent process, of course, throughout the course of every of these phases. Okay, so I talked a little bit as well about a shared decision making between a multidisciplinary team, because one person is not going to make that decision on whether it's appropriate to move forward. It's a whole bunch of people. These are just some of the representatives that I think of, right, that will be involved in that decision-making process. And I think one of the important things is to make sure that the information is shared in a reliable way so that important information is not missed. Now, whether this is a multidisciplinary forum that is scheduled, that is regular, or another method to make sure that that information is shared is a really important piece here. Okay, so when we've decided it's appropriate to move forward, we enter into phase 3, and that's sort of that preparation phase. This is where the patients, they will actually stop their hydroxyurea and start transfusions. They will have their stem cells mobilized and collected, and then there's going to be this manufacturing wait time. And some things that people don't necessarily know is that the time it takes between collection and actually manufacturing these products can take anywhere from 3 to 6 months. So it's not a short period of time. And so that's something, and it's a time when, for some of our patients, fertility preservation can also occur, and I'll talk a little bit more about that in a sec. These are some questions that I would encourage patients to ask, right? How long does this process take? What happens with me during that manufacturing sort of wait time? And also, what support is there in place to help me get to some of these appointments, right? Okay, so what is needed to make this, smooth and successful? The apheresis service is key and essential here, from the stem cell collection mobilization piece to the transfusions or exchange transfusions that are required at least 8 weeks sort of before they get the collection and mobilization. And so having that partner here is really important. And this occurs at a specialized center. So this is a large country. There are patients that live very far away, and so having social work and funding in place for these patients to come for these transfusion appointments for the collection is very important to keep things equitable. They'll require a central line placement, potentially continued transfusion support, and then from the apheresis side, there's actually quite some unique aspects in the collection and mobilization piece for the stem cells from the gene therapy side. So there actually need to be specific standard operating procedures and protocols and specialized training in place for these services that will be delivered. For patients that are undergoing this gene therapy product, it's plerixafor mobilization, not GCSF, and even assessing the adequacy of the collection, so how good these cells are that we're collecting is different from other sort of conditions and other conditions. So I talked a bit about fertility. I mentioned sort of fertility discussion. So the chemotherapy that is provided to allow for the infusion absolutely affects fertility. So this can't be an afterthought. It needs to happen very early on, right? Discussing fertility preservation options, discussing ovarian reserve, semen analysis, right? Hemoglobinopathy testing in your partner, all of this should happen early on and might guide the decision of what is right for me for our patients as well. Referring someone to a reproductive specialist, again, needs to happen early on. So egg and embryo freezing and ovarian stimulation that comes with that takes about 2 to 3 weeks, followed by egg harvesting. And then some women might need additional cycles of egg harvesting. And so that's why this needs to happen early on. There's that period between collection and it should say gene therapy, not transplant, that you can kind of add to have that additional egg harvesting period, but it ideally should have been started earlier. And then the discussion about fertility and endocrine function has to continue on after delivery of the cellular therapy as well. And so from the system side, what is needed? So, a connection or having a named reproductive partner with timely access to some of these fertility preservation procedures is extremely important. And then a clear discussion about the costs and the funding and what might be covered and what might not be really does need to happen early on. And that is an access and equity gap because it's not always covered, right, depending on the patients. So it needs to be discussed. So now we go into kind of the final stages of phase 3 where we're discussing kind of the preparatory kind of phase. We're starting patients on medications. We're reconfirming their organ status. I'm going to quickly kind of go through this, but you need clinical pharmacists. You might need to repeat organ function testing and might need sort of timely access to this because we don't want to delay unnecessarily the hospital admission. And then hospital admission itself. So the timeline takes about 4 to 6 weeks. And you get conditioning chemotherapy, you get the infusion of your cells, and then you get recovery. And so that seems very simple, right? No. These are the questions that I would encourage patients to ask even before this phase. So, what are the side effects of chemotherapy? What happens to my support system? So I think that's a very key thing, right? Some of these patients might be the support system for their families, and they're an inpatient for over a month and require very close follow-up, potentially putting them out of the game for a while. And so social work involvement and talking about that planning needs to happen as well. Just a quick list, lodging and support for the patients. We need a transplant center. We need specialized sort of protocols for supportive care, acute and chronic pain, opioid weaning, bacterial prophylaxis. All of these things need standard sort of operating procedures. And then there's specific sort of target monitoring for the actual chemotherapy in and of itself. And sometimes the sickle cell team is not at the same place as the transplant or where the gene therapy will occur, so coordination for those teams is really important. And finally, we go into phase 5, where we're discharged from hospital, lots of early follow-up, organ surveillance, and long-term follow-up happens. And so this can happen with your sickle cell team and your gene therapy team. And these are the questions that I would encourage patients to ask. What symptoms should I watch out for? Who should I call and when should I call, right? And what happens if I move or transfer care? And so I'm not going to go into too much detail because our next presenter will go into a beautiful discussion about early and long-term follow-up. But what I'll say is that there needs to be shared care, coordination, and ownership, right? So there needs to be clear and explicit roles on who does what in terms of follow-up and responsibility for some of these things for our patients, right? So I'll leave that kind of there. And then I just also wanted to mention psychosocial support, the mental health aspect of things. That should be kind of throughout the journey. In the case of curative therapy, it's kind of identity after curative therapy and what that means, because mental health is just as important as physical recovery. I know I'm a little bit low on time, or I have 1 minute, okay, perfect. Well, I'm just gonna close there and just saying that, this is the journey, right? But it's not just one therapy, it's not just one hospital admission, it's a whole system, right, that's required. And you can see that there are a lot of different barriers to this, but what I wanna say is that we should, continue to really address these barriers, not just in anticipation of this gene therapy, but really just to provide good care for our patients, right? I think gene therapy is not just a treatment, it's kind of a catalyst. It's getting us talking about sickle cell disease. It's getting people through the door talking to me and my team. And so I think that's one of the most important parts of this journey. So thank you so much.
Thank you, Dr. Marinkovic. And now welcoming Dr. Viswabandya. And a reminder, just hold on to questions. We will have a Q&A session after both of the speakers.
Thank you, Dr. Marinkovic. I think that was a fantastic presentation. You made my life simpler so that I can leave some slides so that we can have some more time for discussion. Thank you, SCAGO. This is my first time attending this meeting. Wonderful meeting so far, and I'm looking forward to attend it in future multiple times. So what I'm going to talk today is about the patient eligibility selection and the long-term follow-up in gene and cell therapies. So when you are talking about gene and cell therapies, why those are different? Because gene therapy is one concept, cell therapy also includes stem cell transplant. So that when we are talking of a cell change or a cell therapy, so that you are changing the cell, so that it will be both gene therapy and the stem cell transplantation, and we will see in subsequent slides how to go about it. I have nothing to disclose related to this presentation. So first thing happens, or what comes to mind, is we do know that hydroxyurea is there. We do know that the exchange transfusion is there. We do know that newer drugs are coming up. But when we talk of a cure, there are two aspects which can cure a patient with sickle cell disease. So one is stem cell transplant, specifically allogenic stem cell transplant. What do I mean by allogenic? Means we have to have a donor who gives the stem cells. Autologous is using the cells from the same person. We are not talking of autologous here. So one is the allogenic stem cell transplant. Next one is gene therapy. So donor needed, yes. Whereas in a gene therapy, we are using patient's own stem cell. Is the conditioning required? Depending on the type of transplant what we do, the conditioning can be pretty gentle. What we call it as a non-myeloablative conditioning, where we do not use any chemotherapy, so that the organ damage are significantly low. There are myeloablative conditioning where the organ damage can happen, whereas in the gene therapy, it is always high dose chemotherapy that is called busulfan, by it can have a long-term effect related to the organ toxicity. Rejection, can somebody reject the graft? In the allotransplant, it is possible. Somebody can also have a reaction against the donor cell, even if they are matched, what we call it as a graft versus host disease, which in the gene therapy is unlikely. Takes about pretty long time, 2 to 4 months from the time we decide to do a transplant, and 6 to 12 months from the time we decide to go for a gene therapy. Transplant has been there for 30 years. Gene therapy, in fact, December 2023 is the first time when the gene therapy got the FDA approval. And in 2024, it is the Health Canada approval. So we still do not know the long-term effect, and why that is a bit of a concern. We'll see that one in subsequent slides, but it is definitely promising. And cost in Canada, transplant is publicly funded, whereas gene therapy not yet funded. I will just show you how much does it cost in subsequent slides. So then the question comes as, who is eligible? So when you're talking of eligibility, it is not only one aspect. Somebody has to go through all these three. First, is the disease severe enough? We don't want to take everyone for gene therapy or stem cell transplant, so that the disease characteristic has to be severe, looking at a multiple organ sites, where one may say that, okay, this is the severe phenotype, or this person is having a severe disease where this type of a intense procedure is needed. Fit enough, Because both gene therapy and transplant, they are not simple thing. So the organ functions has to be there appropriately so that how the heart is working, are the lung function good? It may not be absolutely normal, but are they stable enough for the person to be taken through the transplant or to be taken through the gene therapy? What is happening to the liver? Is there significant iron overload? So those are the second parameter one need to look at. And maybe one most important thing is, it is a 6 to 12 months of treatment. So it is not that easy, because the initial process, that just takes about 4 weeks in hospital or 6 weeks in the hospital. But what happens after that? That is the most important aspect one needs to look at. When you talk of an indication for transplant, there are multiple indications. I have put it here, mainly looking at a different organ damage. Those are the criteria. If you look at a trials took patients who had at least 4 crises in 24 months, and the age is between 12 to 45. Just to mention here, I have put it 12 to 45 because less than 12 years were not included in the trial. Situation has changed now. US has approved one gene therapy trial, anyone who is between 2 to 12 years. So anyone is beyond 2 years can be taken for a gene therapy trial, not yet approved in Canada. Canada still follows the trial criteria, which is between 12 to 45 years. So the label, those are the label what I have put it here, and the US has accepted the patient who is more than 2 years, and the Canadian funding is mainly for the age more than 12 years. And most important thing is, if there are no matched sibling, if someone has got a matched donor, then that person needs to go for stem cell transplant, not gene therapy. So these are the other aspects, and the third aspect what we may need to look at, and this is extremely important, a long-term follow-up, fertility preservation, as my previous speaker has very kindly mentioned, funding availability and other aspect. So then the question comes as, how do we choose? If a patient comes who has got all the symptoms, you have two options, stem cell transplant and the gene therapy. I know that the gene therapy at present is not happening in Canada, but it has already been approved, so that it is probably a matter of time. In the next few months or few years, we will see that is a standard process. So when you talk of a sickle cell from a transplant perspective, when I am talking of a match related donor, means someone has got a sibling and the sibling is 100% match. Match means it is not a blood group match, it is a HLA or a human leukocyte antigen match, HLA present on the lymphocytes of the patient. So if that HLA is matching with the donor, we will call it as it is a 100% match. Unfortunately, in sickle cell patients, getting a match is only less than 20%. Means even if someone has got a sibling, that sibling being matched, the likelihood is only less than 20%. Then what happens for the other 80%? If someone has got a blood cancer, we really don't worry too much about the matching, because there are voluntary donor registry, and currently in the voluntary donor registry, there are about 44 million voluntary donors worldwide. So we submit the HLA. Among the 44 million voluntary donor, anyone will be matched anywhere in the world. We collect the cells from there, and the cells will come the center where we are doing a transplant, and we go ahead with the transplant. But that is not likelihood in sickle cell disease, because still the match unrelated donor transplant outcome is not that good. It is still considered as under trial in adult population. Then if someone doesn't have a sibling, you don't have a match unrelated donor, but that person needs a transplant, what to go do? That is the thing where for the last decade, this is getting more prominent, what we call it as a haploidentical transplant. Haploidentical transplant means, like as all of you know, the father and mother will give 50% genes to the son and daughter. So a haplodonor is a related donor who can be parents, who can be sibling, who can be children, who is at least 50% match with the patient. So now having a haploidentical donor, almost more than 90% of the patients with the sickle cell anemia can be taken for transplant. So that has opened the donor pool, and more patients have been approved with the transplant. But the next question comes, is haploidentical transplant is as good as a sibling? Look at the data published. In a sibling identical transplant, in a sickle cell from the adult, 98% of the patients can have an overall cure rate. Another study from a multi-center study on the left side shows 100% of the patients can have a long-term cure rate. Almost similar data from the haploidentical donor from the right side. More than 90% of the patients can have a long-term cure rate in the current setting if they are fit to be taken for transplant. They can develop graft versus host disease. They can develop other complications, but the success can be about 94% plus, and that one is gradually becoming a reality. So what is our experience? We started few years back, and so far we have done about 15 transplants in sickle cell disease. Out of 15 transplant, 13 are from the matched sibling donor transplant. We started haploidentical transplant just about few months before. We have completed 2 haploidentical transplant, and currently 1 patient is admitted on the floor. Out of 15 patients, we have the survival of 100%. So 15 out of 15 patients are surviving when we have done the transplant for them. Long-term follow-up is needed, but there are few patients who have really crossed long-term, and they are really doing well. So it is not that it is a hype, now it is a reality, and we can do that one at Princess Margaret or few centers in Canada. So then how do you choose? So this is the algorithm which was put as a CTTC, or a cell therapy transplantation Canada hemoglobinopathy group. So that if someone has got less than 12 years, currently from the Canadian or Health Canada perspective, they cannot be taken for a gene therapy, so they can be enrolled into trial. If anyone is more than 18 years or 12 to 17 years, we see if someone has got a sibling donor. If a sibling donor is there, they need to go for match-related donor transplant, because Health Canada doesn't approve a gene therapy if somebody has got a matched donor. If it is not, then someone can go for a haploidentical transplant or a gene therapy, looking at which are the conditions which will favor gene therapy, which are the conditions which will favor transplant. Again, I am not going to go through this one in detail. I will only focus on one aspect. This is a white screen, so I will not probably show properly, but look at this one. There are double arrow here in comparison to single arrow everywhere. What does it mean? Is that the stem cell collection, it is not always one-time process. Harvesting sickle cell patient is extremely challenging when someone is going for a gene therapy. So someone may need to undergo multiple collection, and in the trial, it has varied between 2 to 6 collection, and that is one of the reasons why sometimes the process takes longer. So once the stem cells are collected, then it goes to the manufacturer to collect the gene therapy, or to insert or to modify the gene therapy before it comes, and then someone gets admitted. So this is one of the reasons why this timeline takes about 6 to 12 months rather than 2 to 4 months time. So what are the guidelines saying? It is important that we have to have a multidisciplinary evaluation, selection beyond severity. This is the drug what we use rather than the regular use like a GCSF. Lifelong surveillance is required, and the fertility counseling is very important. 2 aspects. One drug we use for the gene therapy is called busulfan. Very carefully it has to be monitored, because this is one of the drugs where one has to adjust the drug dose depending on what is the serum level. If you give higher dose, organ toxicity will be there, particularly liver toxicity. If you use the lower dose, then graft rejection will be there. So a particular level has to be required. For that reason, it has to be, or the gene therapy has to be done in center which are competent in monitoring this and competent in doing this. Second one is fertility. I am not going to go through this one in detail. It has already been discussed by my previous colleague. So then the long-term follow-up. So in the long-term follow-up, few aspects needed to be looked at. Late effect of the conditioning. Conditioning is the otherwise called as a preparative regimen, means the chemotherapy, or in some situation in a transplant we use a radiation, that those type of a chemotherapy or the radiation, what we call it as a conditioning regimen, that can cause long-term toxicity. So it is important to look at or follow up this parameter whenever we are doing the long-term follow-up. This is specifically for the gene therapy, because the off-target editing, insertional mutagenesis, is the correction persist, and how long it persists, those are not theoretical questions. It can happen. Why it can happen? May not be from a sickle cell disease. Look at from the different disease like adrenoleukodystrophy. I'll show that one in the next slide, that why it is important to remember this second column. Sickle damage, why it is also important to do a transplant or a gene therapy early. If suppose a chronic damage has happened, it is not that all organs are going to go back to normal. It will prevent the future damage. But if there are some the chronic damage has happened, which is irreversible damage, then it will be probably difficult to go about. So these are the follow-up which are needed. First 100 days is extremely important. when patient is 4 to 6 weeks inpatient and then early follow-up. In the recovery, 3 to 12 months and 1 to 5 years different follow-up is required, and then 5 to 15 is important. Here I have put the gene therapy product. There are two products. One is called Exacel, one is called Lovocel. Currently in by Health Canada, only Exacel is approved. But why Lovocel is important, because when you look at a integration site analysis, when you look at what is the different type of a testing which is required, insertional mutagenesis, it is important, because this is the product what is called as the Elicel. Previously Lovocel was a little bit of a modification, or Elicel was a bit of a modification of a Lovocel. Patients who have used this one in adrenoleukodystrophy, 7 out of 67 patients, they did develop myeloid malignancy or cancer. So a long-term follow-up for 15 years, that is the reason why it is important. Few organs can be or any damage which has happened, it can be reversed. Few damage which doesn't recover, and that is the reason why a long-term follow-up is required. Extremely important to remember this chronic pain. Neither transplant nor gene therapy totally cures the chronic pain. So that counseling is very, very important. If we are seeing a patient who thinks that the pain, which is the chronic pain, which is there for years together, transplant or gene therapy is going to cure it, unfortunately not. So that it is important when the counseling is happening, those has to be emphasized. Then finally comes down to the most important thing. Is any of this is deliverable? Yes, it is, but not that easy. Exacel cost one time $2.2 million US. Lovocel cost one time $3.1 million US. So gene therapy can be practically given. There have been some discussion happening is that in case we will be using this one in Canada, the cost has to be reduced by at least 39%, but that negotiation is happening. That is the reason why I have put a question mark here. Allogenic transplantation about 5 times less in comparison to any gene therapy product. From a provincial perspective, it will be around 150 to 200,000, and which is funded. So it is important to keep this one in mind and look at the practicability when you think about a transplant and gene therapy. Lastly, 8 points to take away. First, when you are selecting the patients, multiple aspects has to be looked at: severity of the patient, what symptoms, what are the organ functions, and what are the practical aspects. HLA typing for every sibling is required, because if someone has got a match-related donor, that person becomes ineligible to be taken for gene therapy currently in Canada unless the sibling doesn't want to donate. Refer at the first event, particularly doing transplant or a gene therapy early is better if there are severe symptoms. These are not chemotherapy free, so chemotherapy will have its own side effect, so the patients need to be counseled about that. Fertility, one has to look at much earlier, even before the hydroxyurea. When we are stopping from that perspective, 15 years follow-up, cure stops newer damage, may not probably stop all the damages which has happened. And transplant is happening today, gene therapy in future, but we have 2 ways how to cure patients. Thank you very much. Happy to take any questions.
Thank you to both of our fantastic speakers this afternoon. We have about 12 minutes for a Q&A. What questions do you have for our speakers? Dr. Bayless, you had your hand up first.
Curious if any Canadians have gone to the US.
As far as I know, I'm not really sure about that. I don't think that any Canadian has gone to US for the gene therapy.
Hi, thanks a lot for the talks. Just curious about your perspectives on the requirement for having a matched sibling transplant possibility as a barrier to cell therapy, gene therapy from both of you, I guess, just in terms of, it seems like it's a one-way street. If you have that cell therapy or the stem cell treatment and it doesn't work, you're now ineligible for gene therapy. And as far as we know, it seems like the side effects with the gene therapies are much lower. I mean, I think with a match-related sibling, you're probably fairly low risk for GVHD, but it's always kind of lurking in the background. So I was curious, what are your perspectives on the appropriateness of that as a barrier to getting to gene therapy?
Thank you. I think that is a very important question, because gene therapy currently, if someone has had is transplant, then that person becomes ineligible for gene therapy. But I would probably look at it the other way. From matched sibling transplant, which has been so successful now, and few centers almost quoting that 100% long-term cure rate with a multiple organ damage getting reversed, and it is not allowing any progression to happen, I would probably still say that the matched sibling donor transplants are pretty safe at present. So with a gene therapy, the challenge what happens is that even if we say, or all of us want that a patient has to be taken for gene therapy, the mobilization, collection is not that easy. A lot of times when patient goes through the 3 to 4 times collection, still at the end, they may not be able to collect the 20 million CD34 cells, which is required for the gene product to be there. And second thing, I'll be also very concerned regarding the high dose busulfan. Busulfan is an alkylator, and it has been associated with a developing malignancy in future. Sickle cell, as such, we know that the likelihood of a malignancy in sickle cell is there. So I'd probably say that in the current scenario, I look at it that not that either transplant or gene therapy, for that particular patient, which is the better at that moment, so that we have more options to choose now, which was not there before. But gene therapy, I'd probably also at present, I'll not consider that absolutely 100% safe, particularly with a high dose busulfan. And in fact, their platelet recovery and the neutrophil recovery unfortunately takes about 35 to 42 days. So those 35 to 42 days, somebody will be on the floor with a low blood count, likelihood of infection, likelihood of other complications are not that less.
So great talks from both of you guys. It's really interesting to get the Canadian perspective on, particularly on gene therapy. So I'm based in Detroit. We see with some of our partners an increasing amount of gene therapy in the post clinical trial setting, in the real world setting. And one of my big concerns is obviously how much we don't know about long-term follow-up, and how there's a lot of gaps in sort of this 15-year horizon where we really should be doing really rigorous biologic assessment in these patients to really understand what exactly those changes are, how durable they are, the relationship between that durability and the clinical outcomes. The talk I gave earlier when I was talking about the young man on the mountain, and it just, obviously everyone's not climbing Kilimanjaro, but when people have these therapies, they feel completely different. And their willingness to try and do different things, they're not always sort of in your care. And without that type of monitoring and assessment, we don't have the ability to continue to give them guidance. Sometimes they get out of the system and they aren't thought about as sickle cell patients anymore. And so they're sort of, out there in the world without that same kind of coverage of a expert provider to monitor and to assess how they're doing as they're really engaging in a lot of different activities that they weren't doing before. So I'm just curious in terms of how you guys, in preparation for, the future of where you're going to have more patients that are coming on board, how are you guys thinking about those issues in Canada?
Yeah, that's a great question. I think that we're still, we don't know yet, but I do think having something set up, like you've mentioned, right? Having specific follow-up periods and discussing with our patients that yes, you might undergo this curative therapy, this identity change, but there are several unknowns, and so keeping in touch and remaining in touch with the sickle cell team and your cellular therapy team is still extremely important. I know that there might be long-term follow-up registries, right? And then potentially having someone or coordinators that can reach out even via sort of telehealth for patients that might, not be able to come to our specialized center, just to connect with our patients and continue that organ screening, right? I don't think that stops. I think that still should continue because we don't know the long-term effects. We don't know what, will it get better, will it get worse, will it stay the same? We have the idea, but we still don't know, right?
No, thank you.
experience with transplant too, so I'm guessing we'll kind of take from that as well.
No, thank you. But you raised very, very important point. Because we have to involve much of the social worker at that time. It is not the physicians. Physicians can do probably one aspect, but more important that, and when I talk to my US colleagues, exactly the same thing, that the people who have got gene therapy or they've cured from a transplant, now they feel totally cured. They don't have any symptoms. But they have not yet been ready to accept that I don't have sickle cell. Because previously, how they were being supported, what support system was there, but now once they cure, so that becomes extremely challenging that how they will manage that and how they will cope with that coping mechanism is not that easy. Because now they will be fit to go back to school, they will be fit to go back to university, they will be considered as normal people. But that initial coping mechanism and the coping mechanism now, there is a 360-degree change. So I think at that time, I think the support system, social worker system, and it has to be probably multiple people need to get involved from that aspect, that multidisciplinary team, having the social worker support structure is very, very important to see that it is not doing a procedure, it is also how to follow up them, trying to see that they are also getting the best out of this.
Real quick, and so, we think about using the experience of transplant and sort of extrapolating to long-term follow-up with like fetal hemoglobin induction strategies and gene editing. But I think there's just a lot of fundamental differences in terms of what that sort of curative biology means in terms of increasing fetal hemoglobin and F cells and the relationship of that, because there's still an inducible sickle cell related complications that are possible in that context that might not be possible in the transplant context, and how that plays out in the monitoring phase, and what data should we be monitoring, what recommendations we should be giving these patients. I just think we're, in the US, are not capturing adequate data to be able to understand.
I agree. I think how much of the F cells will actually take care of all those symptoms. Someone is having, at least from the lobo cell perspective, the F cells have increased by about 43%. And anything more than 30% of the F cells should be okay. But how long that F cells can present so that the symptoms can get better, I think that is an open question. That is the reason that long-term follow-up will be extremely important to know how things are moving forward.
And I can also draw from so I also work in hemophilia, and so one of the therapies that sort of transformed, not just gene therapy, but it was a product called emicizumab. And so from that perspective, our patients went from seeing us, once every few weeks to once a year. And so I can imagine this might take place kind of that way, because they no longer had bleeds every day. They sometimes don't have bleeds for a year. So it might be similar like this, inducible versus not. And so I think educating our patients, but also having that relationship that we do with our patients from pre-transplant or pre-gene therapy, and continuing that post with social work involvement, with our nursing staff, with our psychologists, if we're lucky enough to have one in our program, are all sort of very, very similar kind of aspects, and very important in maintaining that long-term follow-up and that education.
We have time for one last question.
I'll make it quick. I work with adult patients with sickle cell, and thank you so much for answering most of the questions they asked me. A question I'm not sure was covered: of your 44 patients who underwent the stem cell transplant, how old was your oldest patient? Because that's something that we wonder about. How high can we go? The other quick one is just on behalf of Princess Margaret to thank you for the link that you have on your external website on the process and for undergoing the stem cell transplant, and it's very specific. It's for sickle cell patients. So I'm always referring my patients to go there, and they're going to get the whole kit on what to expect, the process, and stuff like those. Maybe I'm going to suggest, this is just a suggestion, I have you as our ambassador. Maybe we go back and maybe put something for gene therapy, because those are questions coming up. I have listened, I have tried to take in as much as I can, But then when I go back, I want to tell my patients, okay, this is not approved, but it may be coming, down the line. In the meantime, get familiar. So I would love to set them back again to the Princess Margaret website if that can be made available. Just a suggestion.
Absolutely. I think that is a wonderful suggestion. We'll definitely look forward to that.
Okay, so what was...
About age, yes. So in a related donor transplant, I think the age can be up to 50 plus even. But in a haploidentical transplant, people have not preferred anyone going beyond 45 years. And not only that, also how old is the donor. Like if a donor is beyond 50 years, we do know that stem cell harvest may not be that much appropriate. Like when a related donor transplant, we usually collect the stem cells from the blood. That becomes much more easier. But in a haploidentical donor, we'll have to collect the stem cells from the bone marrow. So if the donor is beyond 50 years, then collecting the enough cells from the bone marrow, that becomes a little bit challenging. We can use it from the blood, but for the time being, most of the centers will prefer to use the bone marrow for haploidentical transplant.
Please join me in thanking both of our speakers this afternoon.